Hello, everyone. And now we begin with our American Academy of Ophthalmology Symposium, Debates in Retina, Where Are We Now? Very pleasured to introduce the chairpersons for this symposium today, Dr. Lita Wu, Dr. Taraprasad Das, and myself, Pasant Abdurrahman. In this 19-minute AAO Retina Symposium, we're happy to bring together international experts to host interesting debates on the latest developments in the management of retinal diseases. So now with Dr. Lita Wu introducing our brilliant and eminent speakers.
So we're going to have a slight change in the program because of conflicts. The first set of speakers, the first set of debates is Maria Berrocal and Jay Sheth. I'm going to invite my good friend Maria Berrocal. First-line treatment for proliferative diabetic retinopathy, laser. Maria?
Thank you, Lite. And thank you so much for having me here. It is a distinct pleasure to be in India at this meeting. So laser PRP. We know laser PRP stands the test of time. The DRS way back from 1972 to 75 showed that it reduces the risk of severe visual loss by over 50%. It is cost efficient, has minimal devastating complications. It stabilizes the eyes long term. Most eyes stay stable for more than 10 years after initial stability. Compliance with treatment is not required. If they get lost to follow-up, tragic things do not happen. And it has a very reduced treatment burden. So let's look at complications. Complications of laser include visual field reduction, nyctalopia, can cause some fibrosis. But complications of anti-VEGF injections include visual field reduction also because the visual field reductions, as was shown in Protocol S, has to do with the degree of ischemia, not necessarily the laser. Endophthalmitis, retinal detachment, cataract formation, uveitis and vasculitis, and severe fibrosis. But if the patients are lost to follow-up, and this was published by Obeid in 2018, when patients were lost to follow-up, if they were treated with laser, 2% of those eyes developed traction retinal detachment. But if they were treated with anti-VEGF, 1/3, 33% of those eyes developed a traction retinal detachment, many of them inoperable. They also develop rubeosis and neovascular glaucoma. And we know that patients, diabetic patients, are lost to follow-up between 25 and 50% of them just don't come to appointments. So everybody talks that Protocol S showed similar changes in visual acuity between laser and anti-VEGF, and that we should use anti-VEGFs. So let's look at Protocol S, the 5-year results. In the laser arm, the average number of injections needed, because patients were injected if they had macular edema, were 5. In the anti-VEGF group, it was 19. The mean number of visits was twice as many in the anti-VEGF. They had to come in back if they had complications or et cetera. And even in the anti-VEGF group, 14% required PRP laser. Similar numbers developed vitreous hemorrhage, 46% in the PRP laser group and 48% in the ones treated with anti-VEGF. But this is very interesting, something we don't talk about enough. Cardiac disorders happened in almost twice as many of the patients treated with anti-VEGF. Cardiac deaths in 3 times as many patients in the anti-VEGF group. Total deaths in twice as many patients, and neovascular glaucoma in about the same. So let's think about what happens when you're lost to follow-up. As I said, eyes lost to follow-up do worse if they're only treated with anti-VEGFs. 33% develop traction retinal detachment versus only 2% in the ones treated with PVR. And some come in, like the one on the right, with neovascular glaucoma and lost eyes. And when we inject anti-VEGFs in patients that have a partially attached hyaloid, like this patient, they can develop the crunch effect and attraction rhegmatogenous detachment. You see the same thing in the left. After a mild vitreous hemorrhage, treated with anti-VEGF, developed attraction detachment, and attraction and rhegmatogenous detachment in another patient in the right. And why does this happen? Well, now we have information that anti-VEGFs cause fibrosis. They cause the angiofibrotic switch, which leads to fibrosis and traction retinal detachment, especially when lost to follow-up. When we look at the Yosemite and Rhine data, comparing aflibercept with faricimab, we saw that in the aflibercept arm, 8% at only 2 years developed a epiretinal membrane. So fibrosis happens after anti-VEGF treatment. And let's talk about endophthalmitis, because we all say, oh, endophthalmitis, the rate is so low, it's only 0.01% to 0.26% but that is per injection. And we know that diabetic patients have a higher incidence of endophthalmitis. And when we look at, if we were to treat these patients as per Protocol S, the rate of endophthalmitis per eye would be between 0.2% to 5%, considering the 19 injections. So this is not a small risk. And let's talk about the treatment burden. Okay, PRP, most eyes are stabilized with a full PRP, which can be done between 1 and 3 sessions. But anti-VEGFs, we have to keep in mind, it does not reverse neovascularization, it masks it. If you stop the anti-VEGF, the same neovascular vessels come back. It only suppresses the VEGF for 1 to 2 months, and the ischemic areas remain. So you need continuous treatment almost for life. And when we think about the 19 injections in 5 years for Protocol S, and the 43 visits in 5 years, it's twice as many visits as the PRP arm, even within a study. So let's think about treatment burden. Let's talk about the US, the world's richest country. In the US, 25% of all health dollars are used to treat diabetes, complications of diabetes. That's a quarter of the whole, and it has the costliest health system in the world. The US has 34 million diabetics diagnosed, 10 million with diabetic retinopathy, 2 million with vision-threatening diabetic retinopathy. That would mean over 1 million with proliferative diabetic retinopathy. If we are going to assume they're going to get 19 injections in 5 years, that would be 19 million injections. That's 3.8 million injections yearly. At a cost, the average cost in the US of the visit plus the drug, et cetera, it's about $700. So that would be $2.6 billion a year just for treating proliferative diabetic retinopathy, not including macular edema, et cetera. So PRP treatment, assuming putting a cost of a PRP at $700, it would only be 700 million if we were to treat them all with laser. So cost of anti-VEGF is more than 4 times the cost of PRP in the first year only. And in the patients treated with anti-VEGF, it is a recurrent cost. But let's talk about India. We're in India. India has 180 million diabetics. The prevalence has tripled in the last decade, as in many developing countries. 7.2...
Maria, can you sum up?
Yes. So when we look at this, we would need to treat patients with PDR over 9 million anti-VEGF injections yearly. That would be 760,000 injections monthly. So this is enough to just bankrupt any health system. The burden of the patient and the burden to the health system is simply unsustainable. Thank you.
Thank you, Maria. I'm going to invite now Dr. Jay Sheth to talk about first-line treatment for PDR anti-VEGF therapy. Dr. Sheth.
So at the onset, thank you very much, AAO, APAO, and AIOS for this excellent opportunity to show evidence as to why anti-VEGF therapy is a better treatment option for patients who have PDR. So these are my financial disclosures, none related to the work that is being presented. So we know that PDR is one of the severe complications of patients who have diabetes, and it is primarily driven by an overproduction of the VEGF levels. And this VEGF surge leads to multiple complications, including vitreous hemorrhage, tractional retinal detachments, leading to severe amount of vision loss. Now, historically, all these eyes have been treated by a pan-retinal photocoagulation to manage PDRs. And what is the rationale? So rationale is basically to kill the retinal tissue, and which ultimately leads to a reduction in the metabolic demand of the retina and thereby reducing the VEGF levels. So however, this method does come at a very high price. So we are essentially sacrificing the peripheral normal retinal tissue also along with the diseased part. And to just put into perspective, it's actually like using a sledgehammer to just cut open a nut. So we need better options for this. So therein emerges the role of anti-VEGF therapy, which is a game-changing alternative for managing all these PDR patients. So these anti-VEGF agents, it actually targets the root cause of the entire disease process, that is a VEGF. And there are multiple treatment options which are FDA approved, are available for treatment of these conditions, and with an emerging amount of biosimilars, especially in the developing nations and also in the developed countries. So it not only halts the progression of the abnormal blood vessel growth, but also preserves the overall integrity of the retina. And there are multiple randomized clinical trials, especially the Protocol S, that has compared both these treatment modalities against one another. And it has shown that anti-VEGF therapy can help achieve non-inferior visual outcomes as compared to the PRP treatment. But the benefit actually doesn't stop here. The patients who were treated with anti-VEGF therapy have shown a lower incidence of visual-threatening DMEs, fewer cases of vitrectomy that were needed, and significantly less loss of peripheral vision. So overall, when we compare both the therapies, we are actually saving not only the central vision for the patient, but also the peripheral vision when we select anti-VEGF over PRP in all these eyes. Then there are other studies such as the recovery trial that actually compared aflibercept monotherapy that were given in a monthly dose as well as on a quarterly dose. And it has shown that over 2 years, the DRSS score improved in almost 82% eyes and it was stabilized in 18%. Now here, one very important thing is that there were absence of any cases of worsening of the DRSS that were there. And even looking at the angiographic biomarkers, the treatment with aflibercept led to an improvement in the non-perfusion index, microaneurysmal count, any other parameters. So then another concern is the injection burden, where how many injections do we need to give. So if you look back at Protocol S, there were 7 injections needed in the first year, but from the second year onwards, only an average of 2.5 to 3 injections were needed for those patients. And even the recovery study has shown that quarterly injections are as good as monthly injections, and giving, although there might be a modest benefit with monthly injections. So if we look at the newer treatment regimes, such as the treat and extend, as well as the newer anti-VEGFs that are coming up with a longer durability and those implantable devices, it can definitely help us reduce the further burden of injections when we treat with anti-VEGF monotherapy. The next very important concern is, of course, the cost effect for all these patients. PRP is definitely much more economical when we compare to anti-VEGF therapies. So at first glance, although it may appear that way, but then if we look at Protocol S, almost 50% of the patients who were treated with PRP needed an additional laser session. So when we look at the cumulative cost, although the anti-VEGF may be marginally higher, but with the biosimilars and all coming up, it is definitely going to bring down the overall treatment cost. And what about the healthcare needs? So there was definitely more need for vitrectomies and other patient care that was needed in patients who are treated with PRP alone. So overall, the cumulative cost may increase, as well as we have to also look at the productivity of the patient itself, with multiple hospitalizations that are needed, with PRP causing vitreous hemorrhage, increased risk of TRDs. So all these also need to be taken into account. Then addressing the safety. So the endophthalmitis rate is very, very minimal when we look at the cumulative data. And also meta-analysis studies have shown that the systemic safety is also very good for all these agents. So this is a very interesting paper that was published by Prithvi Mrutyunjay and their group, where they actually compared the rate of laser treatment as well as the rate of anti-VEGF therapy after the publication of Protocol S. So if I look at the lower graph pointed by the red, so that is a PRP, and if you look, the rates of PRP are actually falling. Whereas when I compare with the anti-VEGF therapy, definitely after the publication of Protocol S, there is a greater increase in the rates of anti-VEGF monotherapy that are being advised by the US physicians themselves. And so this trend just reflects an increasing confidence with this therapy modality. And also there are other papers that have published that also confirm the higher rates of vitrectomy as well as vitreous hemorrhage and TRDs with PRP as compared to anti-VEGF therapy. So this was one of the interesting cases that we had actually published in AGA case reports, whereas the patients were treated with 3 loading doses of ranibizumab, and on this side we see that there is complete absence of neovascularization of the 3 loading dose, as well as we were able to demonstrate a reperfusion that is also happening in the areas of retina. So just to conclude, as we move towards an era of precision medicine, it is very clear that anti-VEGF therapy represents a major leap forward in the treatment of PDRIs. So this approach not only targets the underlying cause, that is the VEGF overexpression, but also preserves retinal structure and function, offering our patients a superior quality of life as compared to traditional PRP. Thank you very much for your patient listening.
Thank you. So we have a few minutes. I'd like to open the floor for discussion, and while people get to the microphone, I'd like to ask some words of wisdom from Dr. Das. What are your thoughts on the topic? Between the two? Yes.
I think both Maria and Jay talked about the benefit and cost benefit. So look at that where you are doing it. Supposing you do in India, where patients do not come for regular follow-up, or you suspect that may not come for regular follow-up, most probably in established case of PDR, PRP might do well because you don't lose them. But where you expect that they will come regular follow-up, maybe anti-VEGF is better. Like Jay told, biosimilars might be cheaper than the original molecules. Jay also talked about the productivity. If you look at the visual field, then obviously in the way DRS, ETDRS suggested that larger spots, very confluent spots, then certainly there is a larger visual field and larger contrast sensitivity in the PRP compared to anti-VEGF. But look at the entire thing. I will still recommend that in a low resource settings where patient compliance is less assured, I will think about the PRP. Otherwise, I might still go for the anti-VEGF today.
How about combination therapy?
Combination therapy, a good idea. Nothing wrong in that. One can start with the one, then switch to other. But then I will prefer others comment on this combination therapy. How about you?
I think the combination therapy is a good idea when you have macular edema and also the proliferative retinopathy. But I'm from Latin America, and in Latin America, most of our patients, they didn't come to regular control. So for my reality, photocoagulation is a better choice than anti-VEGF therapy.
Thank you very much. And now we go to Dr. Muna Bend with routine clinical use of OCTA for retina diseases. Yes.
Good morning, and thank you to AAO, APAO, and AIOS for this opportunity. Let me just start with a case that most of us are familiar with, the diabetic who goes from place to place with an OCT of the central 3 millimeters, asking you whether there is an alternative for injections. This gentleman also had floaters in the left eye. And just an hour later, I could tell him the good news, looking at his OCTA, that he doesn't only need injections, he needs laser as well. So I will be speaking in the next few minutes, that there is definitely a role for routine clinical use of OCTA in the retina clinic. These are the common retinal disorders we see in the retina clinic, and if you look at the investigations we do, OCTA forms part of the investigation for almost half of them, maybe a little more. Why OCTA? It studies the vasculature, both normal and abnormal, and also gives you a corresponding B scan. We see the deep capillary plexus and choroidal vasculature, something we don't see on a fluorescein angiogram. It's quick, non-invasive, and most commercial instruments now have standardized protocols. It's easily repeatable if you feel you missed something or you feel you need to look somewhere else. It's very practical for frequent monitoring, especially if you're looking at personalized treatment intervals, which is what all drugs are now looking at. It bypasses leakage. There's no risk of dye allergy, no challenge with IV access. If performed properly, it can replace most indications for invasive angiography. And quantitative measurements are possible, but currently more as a research tool. And this is not a fancy OCTA machine. This is a regular 12 millimeter scan on a standard SD OCT. And this patient with proliferative diabetic retinopathy, center it on the macula. You see neovascals here, you see non-perfusion here, neovascularization of the disc. Center it on the disc and you see there's non-perfusion nasally as well. Similar in the left eye, and you also have the B scans showing that there's macular edema. So quick way to make your decision and explain to the patient. It also helps to distinguish neovascularization versus IRMA. You see here the vitreoretinal interface slab picking up a small area of neovascularization, which is not seen in the superficial slab, and also in the B scan with the flow signal. Whereas in intraretinal microvascular abnormalities, where you don't need to do PRP, the vitreoretinal interface is quite clear. This is a gentleman on a regular follow-up. He has a little uncontrolled hypertension. There's better eye with non-proliferative diabetic retinopathy, sudden blur in vision in the right eye, a little bit of retinal whitening, and an OCTA shows that there is absence of flow signal temporal to the fovea in both eyes, the B scan showing hyperreflectivity of the inner retinal layers, indicating that there is some loss of retinal perfusion in that area. We do evaluate our patients with CRVO every month. This is a patient with non-ischemic CRVO, cystoid macular edema. A month later, you see even though fixation is poor, you have artifacts, you're able to see there is perfusion, there's macular edema. A good result after one ranibizumab. The second ranibizumab, again, if you look at the B scan, everything is fine, but the red flag comes here. There is ischemia indicating that this patient is now progressing to ischemic CRVO. And we all know we have to look at both eyes. This patient came for treatment in the left eye, and if you look at the asymptomatic right eye, there is a quiet little new vessel here, and this, I think, is probably one of the major indications for doing OCT angiogram in your clinic, looking at the fellow eye for a quiet neovascular membrane. You can also do it to monitor whether membranes are growing when you're only observing the patient. Here you see a patient, this was as much as he could get with treatment, there's no fluid, but with each OCT angiogram done at monthly intervals, you see this membrane is growing in size. And then we have the doctor shopper, the world traveler, and the opinion seeker, who has all kinds of investigations done. Someone's done a B scan and said, if you develop a CNV, you need treatment. Someone's done a wide-angled fluorescein and said, yeah, maybe you need injections. And then he comes for a third opinion. And then what I did, I just did a small 3x3 OCTA scan and said, yes, you do have a neovascular membrane under this elevated RP and you need an injection. Incidentally, he was also a genetic mutation for pattern dystrophy. And here is something which is an artifact, looks like a membrane, but it's actually an artifact caused by RP atrophy in the fellow eye. And some things never end. A patient who had PDR with drusen, vitreous surgery, didn't do too well. He vanished, came back one day, all was fine. A year later, everything fine except a few more hemorrhages at the posterior pole. And now we find he's developed a CNVM also, so the next chapter begins. Bilateral choroiditis, very difficult to find anything, but look at the OCTA. It picks up this small neovascular network, shrinks with treatment, also choroidal thickening, which is managed with medical management. This is choriocapillaries flow signal defects due to a granuloma, again, which improves with treatment. The limitations, the learning curve, artifacts can be misinterpreted. We still don't have wide field imaging on all systems. Definitely there is a role in OCTA for clinical diseases. And what's more, it's validated by my worthy opponent, Dr. Sadda, who says he uses it for everything except a PVD. So I rest my case.
Thank you so much, Dr. Muna. And now with Dr. Srinivas Sada, routine clinical use of OCTA for retina diseases, no.
Okay, thanks very much. It's great to be able to debate Dr. Muna, and so I'm going to take the no position. These are my disclosures. So is OCT angiography something that should be routinely used? I'm going to say no. So, Muna, Dr. Muna, I think really did a great job, highlighted some wonderful cases, showed its value in identifying macular ischemia. Actually, as she pointed out, we've been using OCT angiography for a long time. We were involved in its early development. This is actually a paper we published more than 10 years ago, before the technology became routinely available, and she highlighted the use in distinguishing IRMA versus neovascularization. And of course, for macular neovascularization identification, it can be very helpful. And my personal interest, and she cited some of that, is in evaluating the chorea capillaris. But I want to say that's not the question for today's debate. We're not arguing whether OCT angiography is useful, which is what I've highlighted in previous articles. It obviously is, and Dr. Muna made a compelling case for that. The question, though, is should it be used routinely? In other words, is it essential for clinical practice? And so in my mind, for the criteria for a technology to be used routinely, I think it has to be essential in management to improve outcomes. It has to save us time, or it should at least reduce cost. So if OCTA is truly essential, such that it should be used routinely, there must be wonderful level 1 clinical trial data that shows that using OCTA improves outcomes for patients. And we look at the literature for evidence, we find there's actually none. This is quite shocking, right? Considering that we've had OCTA for a decade. Something must be wrong here. And in fact, this is the case, as I said, this was more than 10 years ago where we highlighted its use, and beautiful OCT angiography certainly is very beautiful, but we certainly recognize that a lot of that information can be available in fluorescein angiography, and of course, OCTA does not show us information regarding leakage or velocity. In fact, I think most of us would acknowledge that examination and structural OCT are all we need for the vast majority of our patients. So since I have limited time, I'm going to specifically pull out one of those use cases that Dr. Muna also nicely highlighted, which is macular neovascularization. So when we think about the management of patients with macular neovascularization, and we think about our retreatment decision-making, it's really all about the structural OCT, right? It's about whether or not there's fluid, and that is what dictates our treatment decisions. OCTA, as I highlighted, does not demonstrate leakage. So even when you see neovascularization, for example, in patients with central serous, you don't know whether that's actually the source of the fluid because you don't get leakage information. Now, we and others have described a lot of other information you get, like the size of the lesion, the patterns, and the like, but what do you do with it? There's really no good evidence. And if you want to lower the bar and say, forget about management, what about just diagnosis? Certainly could be useful there, right? And absolutely it can be. But the reality is we have structural OCT features as well that can help us make this diagnosis. Now, I'm not saying OCT is not useful. I'm really arguing the point is it essential. And again, we obviously have dye-based angiography, and of course, anti-VEGF therapy, as we heard from the previous debate, is pretty safe. So you can always use a therapeutic trial when you're uncertain about mechanisms in a patient. So I will highlight that even though I certainly concede that OCT can be helpful in some cases, but there are many pitfalls that make it far from essential. Acquiring the beautiful scans that Dr. Muna showed is not always easy. These require a skilled operator, and there can be many artifacts, motion artifact, loss of signal artifact. Also, I highlighted how we don't get information regarding leakage from OCT angiography. And even for the use case that I've highlighted with regards to macular neovascularization, it's not perfect. Even the best papers on this topic demonstrate the sensitivity of OCT angiography may be less than 80%. In this recent paper, the authors actually concluded it's inferior to dye-based angiography in the detection rate. In addition, we have a whole host of artifacts that were briefly touched on by my opponent. For example, you can have false positive flow artifacts associated with any hyperreflective structure. We and others have published on that. You can have projection artifact from superficial vessels that can confuse your interpretation. And of course, we don't have consistency amongst the different devices. They all have different segmentation conventions, which makes comparability an issue. And of course, segmentation errors as well as other related segmentation issues can make it very difficult to tell what's going on. Here's a patient with macular neovascularization, but I would challenge you to identify the borders of this lesion which blend into the chorea capillaris. And these segmentation errors can be especially tricky. Here's a patient who was suspected to have macular neovascularization. You might think so on the OCT angiogram, but wait a minute, it was just due to a focal segmentation error. So the bottom line is OCT angiography can be quite a challenge to interpret accurately. So let's recap where we're at here with regards to OCT angiography as an essential tool. No evidence that it provides better outcome for patients, clearly gives false positives and negatives, and it's difficult to interpret it, which means it takes extra time in your busy practice. But unfortunately, matters get worse. So OCTA, unfortunately, is not cheap. If you don't have a fast enough device to do it, you have to get new hardware, but certainly there's a software cost involved. And in many countries, like in the United States, for example, we don't get anything extra for doing OCT angiography. So we pay more to have the devices, but we get nothing in obtaining it. Of course, the extra interpretation time means that patients have to wait longer, so they're getting increasingly unhappy. You're seeing fewer patients, so you're burning even more money. So, and of course, the last thing I'd like to highlight is that we actually can get OCTA information from the structural OCT alone. Using AI methods, we can actually infer the OCTA or the vessel information without even having to do an OCT angiogram. And more recently, Rick Spade had published how we can collect other information from the structural OCT data alone, including velocity. So should we be routinely using OCTA? My answer is no, not unless evidence-based medicine isn't important to you and you're in the business of burning money. So in my opinion, I think OCT angiography is great, but it is definitely a nice to have. Thanks very much.
Are there any burning questions for any of our panelists? So perhaps...
Hello, everyone. This is Simon Sitter from Hong Kong. Today...
Wait. So perhaps, Vasant, I want to ask you, what are your uses of OCTA in your practice?
I would go for team no, because I think I believe we need more research whether or not to use OCTA as routinely.
Yeah, I agree with Vas. It's a nice toy to have, but it's not really essential. Okay. Thank you. Okay. Oh, anyone in the audience have any questions? There are microphones in the hall. Please come forward.
Good morning, ma'am. The question is to Dr. Bende, ma'am. Ma'am, in your presentation, you mentioned about oral FFA. Would like to know a little bit more on that. And as far as I know, the adverse effects of oral FFA remains to be the same as the IV FFA. Your point on that, please.
Yeah, it's not exactly part of this talk, but oral
Yes,
FFA
yes,
is usually in children when you find
Yes,
it difficult to get an IV access.
Yeah.
And it's not easy. It gives limited information, but basically it was part of the argument that when you have dye-based, you do have the option of giving it orally for certain situations.
Thank you. Yeah. One another question I wanted to ask regarding the previous talk of anti-VEGF versus PRP. Sir, if you can shed some light, Tara Prasad Das, sir. Sir, have you seen increase in proliferative vitreoretinopathy post multiple anti-VEGF in your practice? Please, your comments.
No, I have not seen actually, but then what been hearing that I'm correlating with the fluorescein angiography also. If you want to look at the real going away of the new vessels on the disc or the elsewhere in retina, I still prefer to have a fluorescein than OCT angio. But then I have not seen after multiple injections of anti-VEGF new vessels coming up in the retina. I have not seen any. Anybody else has seen it? Mona has got a point. Yes, Mona.
Yeah, I think it's not a question of does anti-VEGF cause new vessels, but very often the patient has had injections, thinks everything is fine and doesn't go back for a follow-up. So what we see is rebound, and I think all of us have seen it.
Yes.
And the biggest example was the COVID era, where people wanted to save time, so they gave an injection and sent the patient back, and we operated a lot of them just a couple of months later. So I think it's a real thing if you don't follow up your patient.
Thank you.
The real advantage of OCT angio over the angiography is more of a convenience, because they don't have to find a vessel in a small child or elderly person or people in a hurry or people who had multiple other diseases. Example, somebody got a bad CKD and still you have to find out there is no new vessels in the retina, then OCT angio is useful. OCT angio is also useful in quantifying macular edema, not qualifying it.
Yeah.
So, but then that is the only time we will certainly think of OCT angio over angiography. But angiography is more painful, requires so many other paraphernalia. Example, in India, require a nurse to give injections, and then certainly takes longer time than OCT angio. While was told that longer waiting time interpretation for OCT angio, but then procedure itself, OCT angio is faster than angiography in India at least.
Yeah. Thank you.
I have a question regarding I'm here. Regarding repeated anti-VEGF injections for PDR and foveal thinning.
I'm sorry, we ran out of time. We need
I'm
to
sorry,
move on.
that's all right. That's all right.
Right,
No
so the next set of debates are going to be on myopic tractional maculopathy. Dr. Simon Cito is online via Zoom, so can we play his video, please?
Should be used as the first-line therapy for myopic traction maculopathy. I would like to apologize that I'm not able to attend the meeting in person today, and thank the organizers for the invitation to speak. Here are my financial disclosure, none of which is relevant to today's talk. When we talk about myopic traction maculopathy, MTM, we're not talking about one condition, but an umbrella of conditions that include macular hole, macular schisis, and vitreomacular traction. These conditions arise due to abnormal perpendicular forces from the vitreous and posterior staphyloма, and also tangential traction from contracted internal limiting membrane. To understand what is the best treatment for myopic traction maculopathy, we first need to understand its natural history. It occurs in 8 to 34% of myopic eyes with posterior staphyloma. Generally, it is believed to be a slowly progressive disease with chance of spontaneously improvement. However, around 1 in 10 eyes may progress and develop drop in BCVA over 3 years. Surgery is generally indicated when complications such as foveal detachment, macular hole, or macular hole retina detachment occur. This diagram summarizes all the pathological factors exerted in the macula in MTM. And vitrectomy only addresses a few of these pathological factors. So what are the problems with treating MTM with vitrectomy and ION peeling? First of all, the success rate is generally low. There is also a risk of postoperative macular hole, and also it may accelerate macular atrophy. For example, in this lady with bilateral MTM, whom I treated both eyes with vitrectomy and fovea-sparing ION peeling. The right eye results was excellent. There was resolutions of macular schisis and also no postoperative macular hole. Unfortunately, the result was not so good in the left eye. There was formations of postoperative macular hole. This occurred even after fovea-sparing ION peeling. Postoperative macular hole in MTM will occur in approximately 1 in 10 cases. Although operations with vitrectomy has a success rate over 90%, the visual outcome is generally poor. And the success rate in macular hole in highly myopic eye is also much lower than in non-myopic eye, with a success rate of around 60 to 80%. For example, in this gentleman with myopic macular hole and posterior staphyloma, despite treated with vitrectomy and ION flap, the macular hole failed to close postoperatively. So in summary, vitrectomy and ION peeling has several inherent limitations when it comes to treatment of NTM. It may contribute to myopic macular atrophy, postoperative macular hole formation. It has a low success rate in high myopia associated macular hole, and it does not address the progressive elongations of eyeball or posterior staphylomas. And when we perform macular buccal, we are able to address the perpendicular forces exerted from the posterior staphylomas. Here are the reasons why I believe retina surgeons have not been doing macular buccal as often as they should. First of all, the surgical learning curve could be quite difficult to overcome. It generally requires specialized equipment, and some surgeons are concerned about the outpouching of surrounding retina and contribute to myopic glaucoma. Well, I believe that modern instruments make it slightly easier for surgeons to perform macular buccal with the incorporations of fiber optics. And also, intraoperative OCT could be used to confirm the position of macular buccal. When specialized equipment is not available, there's a cheaper alternative in suprachoroidal macular buccal. And also, I believe that macular buccal could address the perpendicular tractions from posterior staphylomas, making it an ideal surgical option for complex macular hole retinal detachment. In the past, performing macular buccal could be quite challenging because surgeons need to rely on primitive materials such as stainless steel or silicon sponge. However, in modern days, there are commercially available macular buccal that incorporates fiber optic, such as the AJR macular buccal. When these fancy equipments are not available, one could also use the alternative method to perform macular buccal by using the suprachoroidal cannula to inject viscoelastic in the suprachoroidal space. This is an example of macular retinal detachment that was treated with vitrectomy combined with suprachoroidal buccal. As you can see, the anatomical outcome was excellent. This is another case of MTM with fovea detachment treated with combined vitrectomy and suprachoroidal buccal. As you can see again, the anatomical outcome was excellent. And a recent meta-analysis also showed that the macular buccal surgery has a good efficacy in MTM by improving best-corrected visual acuity, reducing axial length, which may counteract the progressive nature of MTM. And also it has a favorable outcome in macular hole closure rate and reattachment rate. And in a randomized control trial comparing primary macular buccal versus primary vitrectomy in macular retinal detachment, it showed that the macular buccal has a higher retinal reattachment rate compared to PPP, although the postoperative VA and macular hole closure rate were similar between the two groups. This slide summarizes the reasons why I believe retinal surgeons should perform more macular buccal to treat MTM. Firstly, vitrectomy has inherent limitation and risk in managing MTM, whereas macular buccal could address the other pathological causes from posterior staphylomas. And for people who are worried about the safety or efficacy of macular buccal, I hope that the recent meta-analysis could be reassuring. And lastly, I believe that a good surgeon should be equipped with different surgical techniques so that when the challenges come, we can rise up to the challenge and face the difficult surgical scenario with the appropriate surgical technique. Lastly, I would like to thank my team and also my mentors from Hong Kong. Thank you.
Yeah, next, I want to introduce Kyoko Hono Matsui. She's going to talk about first-line therapy for myopic traction of maculopathy, vitrectomy.
Thank you very much for giving me a chance to speak. May I have my slide? Not this one. Yeah, yes, this one. Okay, first-line therapy for myopic traction maculopathy vitrectomy. And the primary factors contributing to traction maculopathy are axial elongation, posterior staphloma, and stiffness of ILM and vitreous traction. And macular buckling without vitrectomy addresses the four main causes differently. It pushes the macula forward and shortening the axial length, and it's said to improve staphloma. However, ILM stiffness and vitreous traction remain unaffected. In contrast, vitrectomy does not change axial length or staphloma, but removes the ILM and relieves the vitreous traction. Let's examine these 4 factors one by one. Axial elongation primarily occurs in the equatorial region and does not significantly alter the curvature of the posterior part of the eye. This is why vision can still be corrected effectively with glasses. And next, staphyloma. Staphyloma often encompasses a wide area of the fundus. So the macular buckle does not treat the entire staphyloma, but rather creates a small elevation within the staphyloma. And sometimes a generalized bowing of the scleral curvature is mistaken for a staphyloma. A staphyloma is characterized by an outpouching of a limited area with distinct edges. So wide field OCT is essential for accurately identifying these edges, and 6 mm scans does not show staphylomas. Next, stiffness of the ILM and vitreous traction. While 6 mm scans provide information only around the macula, wide field OCT images reveal the full extent of retinoschisis and its underlying causes. In this patient, the staphyloma edge is seen here with the inner and outer retinoschisis confined to the staphylomatous area, suggesting that staphyloma significantly contributes to traction maculopathy development in this patient. But wide field OCT is highly useful, but cross-sectional images alone may not fully reveal the root cause of traction maculopathy. In this patient with retinoschisis, a horizontal OCT image shows posterior vitreous detachment from the inner retinal surface within the staphylomatous area, along with vitreous adhesion to the fovea. So based on this image alone, one might conclude that the retinoschisis of this patient is caused by foveal traction. But an oblique OCT image reveals 3 lifted retinal vessels with posterior vitreous adhering to the inner retinal surface at the sites of retinal vessels, and multi-layered schisis surrounds the vessels, and outer schisis extends toward the fovea from these vessels. This vascular traction may be missed in conventional 6 mm scans. Radial scans from wide field OCT highlight vitreous traction on retinal vessels in the patients with retinoschisis. And using 6 mm scans, Shimada reported that paravascular lamellar holes were present in 83% of the eyes with retinoschisis, with outer schisis extending from retinal vessels to the macula. This underscores the importance of retinal vessel traction, suggesting that while retinoschisis is macular, its origin often lies away from the macula near retinal vessels. And macular buckling has risks of developing macular atrophy over time, and the procedure also carries a risk of injuring penetrating vessels. Numeral branches of posterior ciliary arteries penetrate the sclera in the macular area. Furthermore, approximately a quarter of highly myopic eyes feature a macular vortex vein, which is also susceptible to injury by macular buckling. And finally, macular buckling may exacerbate mechanical damage to the optic nerve. This is analogous to pressing a balloon with fingers. When one area is compressed, surrounding regions bulge outward more prominently. And in this left figure by Dr. Bolters, you can observe how the scleral curvature of the nasal sclera is significantly altered, and it affects the optic nerve damage. And when the surrounding area bulges posteriorly, this expansion encompasses the optic nerve region. And optic nerve damage is a major cause of visual impairment in high myopia, yet it is often overlooked until its terminal stage. This 60-year-old woman was misdiagnosed with macular atrophy, and by the time she was referred, her visual field was severely compromised. She was barely able to walk. Optic nerve damage develops earlier than in non-highly myopic glaucoma, risking complete vision loss during productive years. So no more further damage on the optic nerves is important. So to sum up, wide field OCT often reveals that vitreostructure on retinal vessels away from the macula is a primary cause of retinal schisis. By addressing destruction internally, it can be effectively released, treating retinal schisis. A less invasive vitrectomy is recommended to avoid unnecessary mechanical damage to the choroid penetrating vessels and the optic nerve. So let's yes for vitrectomy. Thank you so much.
Thank you, Kyoko. The floor is open for discussions. So I have a question for you, Kyoko, or maybe a comment. In all of these cases of macular buccal cases, I think the problem is they haven't really looked long-term. So initially, probably they have good results, but your thoughts maybe on the compression on the very thin choroid capillaris and inducing atrophy in the macular area?
Yeah, I totally agree. The problem is a lack of long-term data and also a lack of wide scan data. So a long-term development of macular atrophy is also important, but I assume maybe optic nerve damage in the long term is a bigger cause. And actually we can treat macular lesions at least to some extent now, but optic nerve damage cannot be cured, and they may lose sight completely at a young age. So this point is very important. So yeah, you are right, a lack of long-term data. And we sometimes, retinal specialists, only take a look at macula, retina, and glaucoma specialists only look at glaucoma. But in terms of pathology mapper, we need to take care of both. So both information is necessary.
Any other questions, comments? Okay, thank you. Okay. So I'm going to invite the next set of speakers. Colin Tan is going to be talking on anti-VEGF treatment for neovascular AMD as needed treatment PRN. Colin, welcome.
All right. Thank you for the introduction, Li-Tei, and good morning, ladies and gentlemen. It's a great pleasure to be here with you. First of all, I'd like to thank the AAO committee for inviting me to speak. It's a great honor. And as always, I get the easy topic here, so this should be a slam dunk. So let's see what we have to say about PRN. Firstly, these are my disclosures. I do get honorarium from some of these companies, but there will be no conflict of interest, not when I'm arguing for PRN treatment, so don't worry about that. So why PRN? One of the reasons to start with is the cost of treatment. Now, when we look at for the patient, in many countries, patients either pay out of pocket or have some co-payment involved. And for these patients, every dose of injection, every treatment carries a cost. And they want to minimize the cost, quite understandably. Some of them are so concerned about the cost that they want to avoid treatment even when it is indicated, when we can show them disease activity on the OCT scans. So imagine trying to convince these patients to undergo a treatment, which is when it's inactive, which is what treat and extend does. So I found it sometimes difficult because patients would say, why are you treating when there's no activity? You can tell me there's no activity, why should we carry on the treatment? And for the healthcare system, we know, of course, that there are many administrators and bean counters out there who always question, do we really need to spend this money? So how do we justify to them that we're treating patients when there's no disease activity? Whereas if we were to do it PRN, we can definitely show a case that we're treating because there's some activity shown. Also, there's the issue of limited reimbursement. In some countries, the public healthcare reimbursements for anti-VEGFs are limited to a specific number of injections per patient over their entire lifetime. Not per year, but over their entire lifetime. And this is especially so in some countries in Asia. And this may be as low as 7 injections for the patient for the entire life. After that, it's out of his pocket. So even if the patient's willing to undergo treat and extend, he may not be able to afford this. And PRN has the potential to lower treatment burden. Now that may sound surprising, but look at this paper from published in the European Journal of Ophthalmology, who showed the mean number of injections for PRN in the top half and in the middle third for treat and extend. For the first 12 months, for months 12 to 24 and beyond, there were actually fewer injections for PRN compared to treat and extend. And the difference in terms of the mean number of visits was only 16.5 for PRN compared to 15.5 for treat and extend. So not that big a difference. This paper also found that the patients in the PRN group had longer mean time between consecutive injections compared to treat and extend. Now let's go on to talk about the patient's perceptions, because this is very important, right? We're dealing with a human being who has their fears, their concerns. So what are they afraid of? Many of them are afraid of injections. I'm sure all of us here have seen these patients. They dread injections and they're in fear of requiring injections. And if you tell them that, okay, I don't need to inject you today, many of them express a great deal of relief. Some of them are even like silently praying to themselves that I'm going to say no. So for those, some have argued about for treat and extend is that, well, at least it's more predictable for the patient. They come in knowing that they're going to get the injection, so they're prepared for it. Maybe so, but let me ask you, when you came into this room, if you were coming into this room knowing that you're going to face a firing squad, and I'm the only person who can say no, would you like to come in knowing that you are going to get your firing squad, or would you like me to have that chance that I will say no, not necessary for you, all right? So which would you like, predictability or at least a chance of not having something that you dread? In terms of patient satisfaction, it's also been argued that treat and extend is more satisfying for patients, but in this paper, in a prospective study of 105 patients who had PRN followed by switching to treat and extend, a majority of them considered it to be equally satisfying, so they didn't seem to make a difference. And in terms of compliance, sure, this applies to any patient in any treatment strategy in terms of compliance, but some patients we know are not so compliant. When we go treat and extend, when we're talking Q16, even Q20 in some cases, some of them will then disappear in the system. Do we really want that? We want more frequent monitoring for these patients. Now, of course, the argument may then come that, well, then you're going to see them more often. Remember, one paper showed that the mean number of visits was similar. But we also need to think outside the box. So, and full credit to Dr. Sada for this point that we were just talking about. We need to think beyond just the traditional, all right? We can have more frequent monitoring, but we need not necessarily bring them in to our clinics because there's now increasingly the use of home OCT, so we can actually monitor these patients and not treat. So one of the reasons for treating extend is because traditionally we had to bring them into the clinics, scan them, and then just treat even though they were inactive. But now we have the option of doing home OCT monitoring and only tell them to come in when they actually require treatment. So that's PRN. And also, what is the optimal treatment interval? This is very variable. Some of them, we know patients who can go long periods without requiring treatments. And on the other end of the spectrum, some of them have worsening activity during the treat and extend period. So I submit that it's better to review patients actively and treat only when required. And those with rapidly progressing disease, some people believe that PRN is less proactive than treat and extend, but I say not so, because for these patients, we can monitor them frequently, either in person or remotely, and this treatment can be given even every month if necessary. So to summarize, PRN is good because it reduces the overall cost of treatment, it reduces the number of injections for patients, it reduces the fears, and active monitoring more frequently, however, how we choose to do it in various systems allows for individualization of the treatment regimen. Thank you very much.
And to debate the con argument for treat and extend anti-VEGF treatment for neovascular AMD, Ramachandran there, please.
Good afternoon, and thank you for the kind invitation for the course. Colin has done a wonderful job talking about a bit of psychology, economics, and now we'll go to a bit of ophthalmology over here, okay? So there's no conflict of interest. So I'm just going to put this slide saying there are a lot of advantages of a monthly system. The PRN is the other extent. In one, you have a high injection load, chance of macular atrophy, lots of injections. The other, there's a high visit load, under treatment, and a lot of disease escape. And probably treat and extend is a biomedia, which is brilliant method. So we're going to look at in three aspects: the past, the present, and the future. But to say first, this is a statement: every visit is a treatment visit. So that's the concept of it, treat and extend. So let's go to the rationale. We talked about proactive. It's a customized treatment where you vary the treatment interval for that. Every AMD is not the same. Every CNVM is not the same, so you vary it. There is less disease escape, which means that you're under control of the disease, and you prevent a lot of catastrophic events with it, and there's a possibility of an exit strategy. I'm going to concentrate on this, a possibility of exit strategy. The basic tenets is that with monthly regimes, you have a lot of injections and less disease escape. With PRN, you have a fewer injections, more visit, but more chances of disease escape. And TAE, the number of injections is more, but the visits and the disease escape is less. The logic behind the TAE is that based on the maximum treatment interval is based on the half-life and the range of the, the disease, the anti-VEGF usage. And the concept, I'm not going into that particularly, you reduce, extend, or maintain the interval between injections based on the visual acuity and the OCT clinical features. The weight of knowledge is tremendously in favor of TAE. All the studies have immense weight of knowledge, and the recommendations from the APVRS with the studies all roughly say that you need, versus a monthly regime, you need 9 versus 11, 16 versus 19 for the 24 months. There are very few RCTs comparing TAE with PRN, and both of the RCTs in the picture are overwhelmingly in favor for better visual acuity control and better CRT maintenance over the years. So it's not just about the number of injections. The meta-analysis and the RCTs are in favor of TAE. So let's throw the real-world blanket over it. If you have a PRN, which is more likely, under-treatment is the norm of a PRN. Everything is good in a clinical trial. When we go to the real world, you're under-treating patients. Why? There is a lack of structure in a PRN, essentially. And it's always a debate of visits versus injections, and there's an absence of an exit strategy. Visits are sometimes as difficult as injections also. And by the concept of TAE, there's a determination of what is acceptable to observe, and that is when the maintenance phase of the TAE has come. Instead of just reducing and increasing the interval, you can maintain it. And all of this is to prevent macular atrophy, and there's an ability to stop therapy with the TAE regime. The customization is that you can maintain if you have tolerable fluid and a stable visual acuity. There is no active hemorrhages, or it can be a physician discretion. And why do you tolerate fluid? It is because the presence of fluid could be protective for the RP, or you could have a surrogate neocapillaris. The CNVM could be providing vascularity also. When you decrease the interval in a TAE, you have two options. One is to let it go for 6 months and then challenge it again, or you could attempt the challenge as soon as the stability is attained. This is interesting. The studies which say that you switch from TAE to PRN. Dr. Colin was talking about satisfaction, but even the dropouts of TAE were doing better than the dropouts of a PRN regime. That is very heavily in favor of the sequential treatment that the TAE patients had received. Defining an exit strategy in TAE is 3 consecutive injections at 3 to 4 months interval, and then going into an observation phase. But it's very hard to define an exit strategy by nature of the PRN. You're watching for disease. You cannot restrict or define this is going to be your exit strategy because you're just watching. And once you have stability in a capped PRN regime, you did 3 monthly for a year and then 6 monthly for 2 years, and this sounds suspiciously similar to a TAE regime. By virtue of the PRN, that is, you're watching for the disease coming back, the physician is not able to define, okay, when am I going to exit from this strategy? The visits keep on going, and then when do you define, okay, I'm not going to see this patient anymore because he is not at a risk of having a recurrence. And that is the main defect of a PRN strategy. And when there is reactivation, in a TAE, it was 13% in 9 months. And only 2% of those patients had a severe visual loss. That is after a proper treat and extend with careful monitoring. And on the whole, 86.5 patients had nil recurrence if the treatment interval was maintained at 12 weeks. That is, a 12-week personalized treatment, if it could be attained, you had a majority of patients not recurring. On the same hand, the presence of a pigment epithelial detachment was a key feature to say that the recurrence was possible. There are extensions that you do in TE. The first extension, you have to look for tolerable fluid and say whether I can extend and maintain it. If it's a second failed extension, you have to differentiate between degenerative or exudative intraretinal fluid. So stopping a strategy could also be due to the medical futility. And there's a well-defined study called the TES, Treat, Extend, and Stop by Adrian et al., which tells us how to stop. And of that, you can see that 54.8% patients still had a visual acuity better than 20/40 if applying a proper TES strategy. Just a quick word to the future. Incorporating OCTA into a TA strategy, looking at the vascular growth and setting your intervals could be a future line of thought. The newer anti-VEGF drugs with longer durations, longer suppression of anti-VEGF could extend your treatment intervals by more and also give a lot of validation to the strategy. And artificial intelligence, looking at various components, looking at OCTA regression of the vasculature and predicting a model of recurrence would also be able to predict what is the treatment interval for these patients. Thank you.
Thank you. Will you join here, Oni? From either of you, could you tell us what is the cost benefit or costing of the patient, cost of the patient and the family, whether do a PRN or treat and extend?
So what we see with the PRN, that
the
is
cost.
The cost.
Cost to the patient and the family. There's a cost involved, right, when you give anti-VEGF?
I couldn't put a cost of peace of mind basically. If I have a disease under control and I'm very strict with the protocol, and for years of experience that all of us have, we see that patients are doing well and suddenly they turn up with one visit with tremendous loss of vision due to a subretinal hemorrhage or a foveal involvement or an extension. So in those patients, see, if you're looking at a geographical location like India, we're worried about the cost factor. But there has to be some of those patients where you want to give an extremely good visual control or a disease control, and they are willing to take the treatment of a treat and extend. And those patients, I would definitely offer it because I'm a step in front of the disease there. My logic being that with the current availability of OCT, OCTA, and the possibility that you are injecting on time, makes for a more robust visual acuity maintenance.
In that case, you're assuming that throughout the life of the patient, the disease remains pretty about the same, which is not exactly the case, right? So, if you assume that, you're going to do 12 weeks, sometimes there's an activity and then you're going to get a breakthrough.
So that is the last thing I'm assuming there. I have the versatility of modifying the disease interval. So if I decide that the disease is not controlled by a 6-weekly injection or an 8-weekly injection, the next opportunity I go down to 4-weekly. And what do we see? In the course of the disease may be most active at a particular point of time, and then the activity reduces, but you have no control over the recurrence rate also. But the status of the visual acuity maintenance over long periods of time seems to be better with the treat and extend.
And finally, for Colin, I think, PRN really would have its day whenever we have home OCT, definitely. I think we need to move on.
Okay, the last set of debate is on central serous-choroidal retinopathy. I'm going to invite a yes for PDT from Professor Jose Rosa.
Thank you very much. Good afternoon, and I want to thank the organizers of this symposium for inviting me and to have the opportunity to come to this magnificent country. So these are my conflicts of interest. First-line treatment for central serous choroidal retinopathy may include observation, photodynamic therapy, or subthecal micropulse laser. Observation, because many of the cases are resolved spontaneously, so observation is often the first-line treatment. Photodynamic therapy involves activity in verteporfin, abnormal blood vessels, and the choroid, and these release the free radicals that obliterate the abnormal blood vessels. And subthecal micropulse laser can reduce the central retinal thickness and improve visual acuity without damaging the retinal tissue. PDT was first reported in 2003 and have a direct effect on the choroidal circulation. Late and collaborators described the use of half-dose verteporfin. 85% of treated eyes showed complete resolution of the neurosensory retinal detachment and or the pigment epithelial detachment, but only 1 month after the treatment. And Ribarli and collaborators evaluated the treatment efficacy of standard fluency PDT versus low fluency PDT using microperimetry. And the study found improvement of macular sensitivity following both treatments. And long-term studies have demonstrated the safety of half-dose and low fluency PDT in the treatment of this pathology. And the PLACE trial, comparing half-dose for a dynamic therapy versus high-density micropulse laser, the primary endpoint was to complete the disappearance of subretinal fluid at the first evaluation visit at 6 to 8 weeks after treatment, and the second outcomes were the anatomic result at the final evaluation visit at 7 to 8 months, the change in best-corrected visual acuity, the retinal sensitivity, and the vision-related quality of life. At the first evaluation visit, also at 6 to 8 weeks, subretinal fluid had resolved in 51% of half-dose PDT-treated patients and only 13.8 patients with subthecal macular micropulse laser. At the final evaluation visit at 7 to 8 months, 67% of patients with half-dose PDT versus 28% of patients with subthecal micropulse laser had no subretinal fluid. So the difference is high. At the first evaluation visit, PDT-treated patients showed a significant increase in best-corrected visual acuity and a significant higher increase in retinal sensitivity on microperimetry. However, the improvement of vision relative quality of life was similar in both treatments. Another analysis from the same trial suggested that PDT was superior to micropulse laser, regardless of whether the leak was focal or diffuse on the fluorescein angiographic exam. And in this meta-analysis, comparing the therapeutic effect and safety of subthecal micropulse laser versus photodynamic therapy with 790 eyes from 4 randomized clinical trials and 5 retrospective studies. The results were that there were no significant difference in the overall effect with central macular thickness, the adverse events, complete resolution of subretinal fluid, and treatment response. But PDT showed greater efficacy in the complete resolution of subretinal fluid. Also, in some cases, subthecal micropulse laser may be considered as competitive alternative to PDT for treating central serous retinopathy. In conclusion, the choice between photodynamic therapy and subthecal micropulse laser for the treatment of chronic central serous choroidopathy has been the subject of several comparative studies. The available evidence suggests that half-dose PDT is generally superior to micropulse laser in terms of anatomical resolution and functional improvement in patients with central serous choroidopathy. Thank you very much.
Thank you. Now I invite Professor Wu to talk on the micropulse laser for CSCR.
Thank you. So these are my disclosures, of which Lumimur Medical is a producer of the PDT laser and also the micropulse laser. So CSCR is characterized by choroidal hyperpermeability, PD, and retinal neurosensory detachment. In most patients, there's spontaneous resolution, and in some patients, the disease becomes chronic with ensuing visual loss. So for these patients, the treatment has been used to treat these eyes. Adverse effects from PDT include transient reduction of macular function, RPE atrophy, choroidal non-perfusion, and secondary CNV. So in order to alleviate these side effects, investigators have used either half fluence or half dose of PDT, and both PDT protocols were effective in improving best-corrected visual acuity and eliminating subretinal fluid. However, choroidal hyperperfusion still occurred. The subthreshold laser eliminates iatrogenic damage from the laser photocoagulation and is based on the principle that each laser pulse is divided into repetitive multiple short pulses separated by an off period, which allows the tissue to cool between the short pulses. The importance of multi-spot in subthreshold is that confluent laser therapy is possible, and there's a lower risk of undertreatment with the multi-spot. Monospot is very difficult in application when you have these invisible treatments. The most common cause of treatment failure is undertreatment. So my esteemed colleague, Dr. Jose Roca, was the first author of this paper where we sought to compare the functional and anatomical outcomes of eyes with chronic central serous treated with the yellow subthreshold laser versus half-dose PDT at 12 months of follow-up. This was a retrospective comparative study of 92 eyes treated with yellow subthreshold laser and 67 eyes treated with half-dose PDT. Chronic CSER was defined as the persistent subretinal fluid for 6 or more months. These were the treatment parameters for the subthreshold laser. Note here that it was a high density, and by that we mean that there was no spacing between the burns. In contrast, PDT, this was half dose, so rather than 6 milligrams, we used 3 milligrams, and 15-minute infusion, laser activation for 83 seconds, and the spot sizes ranging from 400 to 2,000 microns. The baseline characteristics between the two, the subthreshold laser and the PDT groups are here. You can see they're pretty well matched. And the 12 months results, you can see here that both were effective in reducing both the central macular thickness and the subfoveal choroidal thickness, but in terms of corrected visual acuity, the subthreshold laser was better. Here we see a little bit more detail, and you can see that the numbers suggest that the patients treated with the micropulse laser did better than the PDT. And you can see here the curves above the PDT. Let me remind you, this is on a Logmark scale, so better visions with the micropulse laser. In terms of anatomic outcomes, the PDT did a little bit better than the subthreshold laser. And the number of recurrences, you can see here that numerically there were more recurrences in the micropulse laser compared to the PDT, but these was not statistically significant. In terms of complications, one eye developed CNV in the PDT group. Cases here, you can see the pre-treatment images, and then after the subthreshold laser, similar case here prior to PDT, and both you can see are able to improve the vision and get rid of the fluid. In comparison to other studies in the literature, our results are very similar. These are all retrospective case series. And another one that is a prospective study gave about the same type of results. This is half-dose PDT versus yellow laser, and you can see here the improvement in corrected visual acuity was similar in both groups. And this is the place study that Dr. Roca mentioned previously. And if you look at their protocol, they said that for the micropulse laser, it was supposed to be high density. But note that they used an 810 nanometer laser. And the 810 nanometer laser does not have the patterns. So you had to individually give the treatment and assume that you are not under-treating. So we wrote a letter to the editor, signed by Dr. Roca himself, and we asked that the laser were positioned adjacent to each other in a non-overlapping fashion. Try to imagine doing this treatment in vast areas of the fundus where the burns are actually invisible. So definitely there was under-treatment. So, and this is a prospective study from Hong Kong that actually showed that both the half-dose PDT and the yellow micropulse laser are viable options for chronic CSCR. And in conclusion, both the half-dose PDT and the yellow micropulse laser are effective in restoring the macular anatomy in eyes with chronic CSCR. And it appears the yellow micropulse laser has a more beneficial effect in visual acuity than half-dose PDT. I didn't say that, Dr. Roca said that. Thank you very much for your attention.
Do we have any questions from the audience?
So I'd like to make a comment. So the reason we start doing a micropulse laser is that in Latin America, we do not have access to PDT since 2011. So the only option that we have to do for treat these patients is micropulse laser. In Asia, it's different because you guys have verteporfin available. But in our part of the world, we just don't have PDT.
We don't have in India either.
Oh, okay.
We used to have verteporfin for neovascular AMD once upon a time, but then the dye might be still available, but the lasers are not available, so we can't do it.
So Colin, how about in Singapore? Do you guys have easy to get PDT? So Colin says yes.
You can all come up to the, we have a
few
photograph at the end, so if you can ask all of you, Vas, Jay, Uni, Muna, Colin, Okino, please. Any question from the floor, please? No? Okay, we still have 7 minutes there, please.
I'd like to make a comment. I do think the laser issue is a serious problem. I think that there is a company that now makes a new PDT laser, because the old companies like Coherent and Zeiss that used to make PDT lasers, they're not. So I have to say that within the entire UCLA system, you know, the laser that we have at Doheny currently is the only functioning one. So even my colleague David Saraf, he sends me his patients for PDT because, and I do find it is the most effective treatment. I would say it's the rare patient whose fluid doesn't resolve after treatment.
Also has that 25% of neovascular AMD in India are also PCV, and PDT works better in PCV compared to other form. So there is a particular need to have PDT laser and PDT Udine or any other photosensitizing dye in India required.
Well, I would say that, you know, because we have the second generation therapies now, the anti-VEGF now bispecific therapies like Frismab, obviously everyone's seen the Salween results, you do get pretty good control of PCV, but you're probably, I'm sure you're right, there are going to be maybe fewer patients, but still some patients who probably need to have a thrombotic closure. So you're right. So I guess, you know, I don't know what else to do to make the case to the companies to produce this laser. But in the US, we're hoping that Bausch & Lomb is supposed to market a laser from another company that makes it, that hopefully will become available, because everyone is so scared that when their current laser becomes not operational, it's the end of being able to do PDT.
I'm also encouraging one Indian company to produce this PDT laser, but then I do not know they'll succeed convincing them or not, because companies look at the market size and what they will sell for this year or the coming years.
I think, I agree. I think newer anti-VEGF agents are definitely beneficial for at least PCVs. So we don't feel the need much for PCVs. For PDT, but the main important role is patients who have those chronic CSERs or CSRs with subfoveal leak. So those are the cases where we really miss the PDT in our clinical practice, at least in India.
And the world is only getting more stressful. I suspect we're going to see more central serous, so we need it.
Thank you very much for the fruitful debates, and now we wrap it up. Thank you to the audience who attended today. And thank you, everyone. And now we go for a photo of everyone. Thank you.